So let's talk the anaerobe section of the gram-positive rods or bacilli, which is Clostridia, including Clostridium tetani, botulism, then perfringens, and septicum, and the last one is difficile. So Clostridiae are the spore-forming. Clostridiae are the spore-forming anaerobe and gram-positive rod, and they are obligate intracellular rods or pathogen. So the first one is tetani. Tetani cause tetanus, and how this works, the tetani is incorporated in the soil, or actually the tetani is the spore forming bacteria present in the gut of the animals, and the soil which is contaminated by animal manure is pretty much infected, and that is the mode of the route of transmission for human. So if a person having a trauma, so that trauma is infected with the soil, then at the traumatic site or the wound site, there is a localized non-invasive bacterial inflammation, and this inflammation from the soil goes into the trauma site, and now it move retrogradely from the site from the axon into the nerve terminals, retrogradely move into the axon to the spinal cord anterior horn Renshaw cells. At the Renshaw cells, they releases tetanospasmin, which are actually the proteases which cleave snare protein and prevent the fusion of different kind of neurotransmitter, especially the prevent the fusion of inhibitory type of neurotransmitters, especially the important one is glycine and GABA. Prevent inhibition of inhibitory type of neurotransmitter, and it leads when there is no inhibitory neurotransmitter, so there is a overall overactivation of the stimulatory one, acetylcholine, and it leads to spastic paralysis, also known as tetanus. So this toxin causes this prevention of neurotransmission, causes tetani, and in this tetanus it actually causes spastic paralysis. There is a lockjaw symptom, there is a lockjaw, unable to eat or drink, and there is also rhizus sardonicus, which is actually the opening, the elevation of the eyebrows, and the contraction of the facial muscle, making a picture like this. So it seems like the patient is pretty much elevating his eyebrows and showing his teeth. So this is a rhizus sardonicus. Then there is a opisthotonus. There is a spastic paralysis of the spinal extensors, opisthotonus, and there is arch-like back of the human body and trismus. So this is all about the tetanus thing, and it complicate this. This is the picture of an risk factor kid which is unvaccinated, because whenever the patient is unvaccinated, it transplacentally releases IgGs, and these IgGs protect the person for a few years of life. So especially the unvaccinated or unbooster dose makes a person very much vulnerable to tetanus. So if a person is infected, then how to treat? We give antitoxins, which are the preformed immunoglobulins, and these antitoxins or plus minus booster, we can may or may not give booster. These antitoxin, they cancel out this toxospasmin proteases and resolving the symptom. We can also give antibiotics to cope up that obligate intracellular bacteria to kill those colonies. We also use diazepam for skeletal muscle contraction, muscle spasticity, and also cleaning of bone debridement. So in order to diagnose, we just need a clinical picture is enough. In order to diagnose, picture clinical picture is enough in order to diagnose tetanus infection. So this is the general important points, highly testable important points from tetanus bacteria. The next we have the botulism. So in the botulism section, botulism, so again Clostridium botulinum, spore forming. So how the spores come? The spores come from the honey, bad bottles of honey. Spores come from juices. Also spores come from the food borne, so they can causes uh, how this spore. So if a neonate is ingested honey, and it has a lot of spore and heavily spore, there are a lot of spores in in that honey. So these spores germinate and release Clostridium botulism, which releases a toxin known as heat labile toxin, botulinum toxin, and it is again a proteases cleaving the snare protein, inhibit the release of stimulatory presynaptic in the presynaptic stimulatory acetylcholine. So there is no stimulation, only flaccidity or flaccid paralysis. So there is a flaccid paralysis, which is a descending type of flaccid paralysis, and in this baby there is this is also known as floppy baby syndrome. There is a dysarthria, problem in speaking. There is a dysphagia, problem in eating. There is also descending paralysis, 1 2 3 descending paralysis, dysphagia, dysarthria, and diplopia, and autonomic nervous system muscarinic or nicotinic abnormalities. So this is botulism toxin, and this causes this type of inflammation in this type of infection. So how to diagnose or how to diagnose infantile? First, how to diagnose this botulism? Clinical picture only, and also we can detect the infantile version of the botulism by detecting stool spores and stool toxins. Also we do electromyography, and which shows that upon stimulation there is a decreased compound myo or muscular response after stimulating that particular muscle. So how to treat? We just give immunoglobulins, human botulism immunoglobulins, which fight with those toxins and causes treat this condition. So this botulism toxin has a lot of clinical uses in which we use a Botox, which is actually a localized botulism toxin A, which is a botulism toxin. This Botox is used in perimeter cosmetic field in order to clear those wrinkles, and used in the uh, aesthetic industry. And also we give Botox to the patient which are suffering from focal dystonias or spasm, or we also give botulism to a person having a hyperhidrosis or hyper sweating. So this toxin goes into the nerve terminal and block the nerve signaling. So in order to decrease the toxin, in order to decrease that toxin, in order to decrease the sweat secretions. So the next one is we have the Clostridium perfringens, and this perfringen, this is a heat labile enterotoxin. And how this causes bacteria. There is a two type of perfringen toxins. First one is alpha toxin, which is a lecithinase, which is a major virulence factor, and it is a lecithinase. And this lecithinase, as we know, that this is a phospholipase, and this phospholipase is a cell membrane degrader. And this cell membrane degrader, it actually causes degrade the cell, especially the muscular cell. So this toxin, first lecithinase, and also it increases platelet aggregation, and also increase the expression of multiple endothelial and vascular adherence molecule that for example the ICAMs, the PCAMs. We have discussed this in our lecture, in which there is a diabetes, or how the leukocytes come from the endothelium, attached to the endothelium, and then migrate into the migrate across the cell. So over there is ICAMs and ECAMs, and they help to attach different type of cells in the body in order to diabetes from in order to migrate those especially the neutrophil. So they increases platelets and express this adherence of platelet adhere to the molecule, which leads to vaso-occlusive thrombogenesis or vaso-occlusion. And this vaso-occlusion is very much enough to causes the decreased blood flow and causes necrosis. So this type of necrosis is known as gas gangrene, traumatic type of gas gangrene syndrome, in which there is a soft tissue crepitus, and this vaso-occlusion also causes hemolysis, which is a double zone hemolysis. So this myonecrosis. So muscle cells are very much important. This is also if a patient having a burn injury over the compartment of the leg, and then the leg swell in the few years, and it is suffering from suffering from a very painful condition. There is a swelling, cellulitis, and so this is the mechanism over how alpha toxin causes gas gangrene in that patient. So there is also a toxin known as heat labile enterotoxin, which binds to claudin, which are the molecules, cell to cell attachment junction molecule, and also it interferes with the tight junction of the cells, So once the tight junction or the junction between the cell disrupted, they leads to increase in the loss of fluid. So this type of fluid loss is known as uh, food poisoning or the diarrhea, food poisoning or the diarrhea, water predominant diarrhea. So this food poisoning has happened very delay onset, like you ingested a heavily stored contaminated food, and we preserve that food is at less than 60 degree temperature. So over there the spore germinate and causes and a person consume that food, so there is a delay onset. It means that over 10 to 12 hour there is a appearance of gastroenteritis or a diarrhea, watery diarrhea, which resolve ultimately self-limiting, which resolve in 24 hours. So this is how the Clostridium perfringens can causes gas gangrene and foodborne poisoning. There is also a non-traumatic type of Clostridium septicum, which can cause non-traumatic type of gas gangrene. As we have discussed that the Clostridia are the anaerobe normally present in the gut flora. So if a person, non-traumatic mean there is no trauma on the person body or on the external surface of the body. So non-traumatic mean there is an internal or underlying perforation in the intestine, underlying gut perforation, which is because of the malignancy or because of inflammatory bowel diseases or other malignancy. So this underlying malignancy give that flora a way to causes in non-traumatic type of gas gangrene into the body. So this is a major risk factor for causing non-traumatic gas gangrene in the body. So the last one we have Clostridium difficile, and this difficile is very much tested, very much interlinked. So Clostridium difficile. So how this difficile happen? If a person is recently hospitalized, or if a person use antibiotics, especially the Clinda version, the penicillin, the Cef, the quinolones, if the person uses them, or if a person uses PPIs and he is old, then there is a chances of anaerobic Clostridii overgrowth in the body, because these antibiotics disturb the GIT flora. There is a anaerobe overgrowth in the body, which leads to the release of toxin A and toxin B. A is pretty much simple, that it recruit neutrophils and activate them to release cytokines and causes inflammatory fluid loss or diarrhea. Pretty much simple, very straightforward. But the toxin B is very much complicated. It actually complement B, it actually induce actin depolymerization. So this actin depolymerization is actually disrupt the cytoskeleton and causes the mucosal death. This causes mucosal inflammation, and this toxin causes mucosal death or bowel wall death, mean necrosis, or there is a pseudomembranous qualisis. So these two toxin come into overgrowth into the GIT and causes a pseudomembrane colitis. Pseudomembrane colitis with abdominal pain and fever, obviously because of the cytotoxins. So this causes pseudomembrane colitis. Now if a person is untreated or left untreated, the complication is this membranous colitis leads to toxic megacolon, or there is a entire fulminant colitis, first the one part is affected, now the entire GIT is affected, and then it can also cause ileus, and if the infection disrupted, then it can cause a shock. So this is how the interlink between the different recent hospitalization, clinda, and PPIs in old person. There is overgrowth of this bacteria. So in order to diagnose this, in order to diagnose, these are the risk factor which are strong risk factors. This is also strong risk factor. So how to diagnose? We use PCR in order to for the gene which encode beta toxin, which encode toxin B. So this we diagnose this with that toxin B, which it is a single best, it is the best test in order to diagnose. Then we can do also stool antigen testing, which is a secondary type of test, but this single best test can evaluate, can readily diagnose this Clostridium toxin, and also the history clues to that. So how to treat? We give orally oral vancomycin, or we give oral metro, or we give fidaxomicin, which inhibit, fidaxomicin only inhibit the RNA polymerase of the RNA polymerase of this bacterial cell, inhibit this its replication. Also, if a person has a recurrent case, we repeat this, and we either repeat the regimen, or we give a transplant of the microbiota, fecal microbiota transplant. So how to prevent this? We use, in the hospital setting, we use frequent hand washing before and after touching every patient, and also we give sterile gloves in order to handle that secretory secretions of the patient, and also we use gowns in order to protect the physician from the infected patient. So this is how Clostridium difficile going to cause a lot of different conditions. Pseudomembrane colitis is, pseudomembrane is a white yellow type of plaque, can be detected on biopsy. So this is all about the Clostridia part of the anaerobic gram-negative bacteria.